afternoon, everyone. I am Dr. Lee-Anne Godinho. I'm a physician and I work in Mediclinic Midstream Hospital. I am going to be presenting today a presentation by the name The Old Person Who Falls. Let me just see to go on. So what is a fall? A fall is an unintentional event that results in the person coming to rest on the ground or another level. Usually it can be described in three phases. The first phase is the initiating event that displaces the body's center of gravity, and this is usually due to extrinsic factors such as environmental factors. Just an example there would be a loose carpet. And then intrinsic factors such as unstable joints, muscle weakness, and unreliable postural reflexes. Phase 2 is the failure of systems to maintain the upright position. Again, this could be due to intrinsic factors such as a loss of sensory function, loss of proprioception in the feet, for example, impaired central processing, and muscle weakness. And then phase 3 is the actual impact of the body with the floor, resulting in an injury. So falls have been described as one of the geriatric giants by Prof. Isaacs in the 1960s, along with weight loss, incontinence, confusion, and failure to drive. Just looking at the health burden of falls, in other words, the morbidity and mortality, we don't have a lot of South African data, but in 1986 in USA, there were 8,313 deaths due to falls in the USA in persons older than the age of 65. The leading cause of death due to injury in elderly is because of falls. And falls are extremely common in the elderly. A quarter of people with the age of 65 to 74 and 1/3 of people 75 years and older will report falls within the last year. Having said that, most of the falls do not require any medical attention and only result in minor soft tissue injuries, and only about 3 to 5% of falls in the elderly result in fractures, and less than 1% result in femur fractures. So although it can seem fairly common, femur fractures in the elderly, it's still a small amount of the falls resulting in this. But in those who do develop femur fractures, the effects are often devastating. Fractures are the most common serious injury resulting from falls in the elderly. Usually these fractures involve the femur, the wrist, the humerus, and the pelvis. And the one very important compounding factor is that of osteoporosis. And then orthopedic injuries further impede the mobility of the patient. In a patient who perhaps already has a problem with mobility, then becomes further impaired. And there are significant psychological sequelae due to falls. There is a post-fall syndrome where there is basically significant fear of a future fall in the patient and in the family or the caregivers of the patient. So in that case, often the patient or their family members or caregivers restrict their movements due to the fear of a future fall. Ultimately, this then results in a reduced quality of life. This diagram just demonstrates the vicious cycle that occurs, resulting in further loss of independence in an elderly person and reduced quality of life. You have falls resulting in injury and fractures, which then result in further immobility, If they are rendered immobile due to fracture, they will develop further muscle weakness. Due to immobilization, they may also have the development of venous thromboembolism, such as a DVT or a pulmonary embolism. They may develop urinary tract infections as a result of urinary catheterization. For instance, if somebody is bedbound for a period of time, they will develop lung atelectasis and pneumonia. And then, as I mentioned, this results to the psychological fear of falling and fear of mobilization, which results in further reduced and impaired mobility. Other factors which then impair the mobility are sarcopenia, muscle weakness, frailty. It can also be due to neuromuscular disorders such as Parkinson's, arthritis, joint instability, postural hypotension, which is commonly seen in the elderly, impaired cognition, resulting in impaired judgment and perhaps not behaving, doing things that are no longer safe. And sensory deficits such as hearing loss or vision loss can further lead to impaired mobility and falls. So what are the risk factors for falls? Generally speaking, these risk factors are very much multifactorial, resulting from the convergence of intrinsic, pharmacological, environmental, and behavioral and activity-related factors. So what is frailty? I've mentioned it a couple of times. Basically, the definition is an aging-related syndrome of physiological decline characterized by marked vulnerability to adverse health outcomes. So basically, it is elderly patients that have reduced physical reserves, and therefore this leaves them vulnerable to stressors such as falls, infections, etc. And the symptoms, this is just a diagram with some of the symptoms and signs of frailty. As you can see, it results in weakness, slow walking speed, a low level of physical activity, fatigue or exhaustion, and unintentional weight loss. And these patients go from using a walking aid to becoming slowly more frail and losing their independence, essentially, and their quality of life. Just going into some of the details of intrinsic risk factors of falls. Some of the demographic, age older than 65 or 65 and older will be an increased risk of falls, and the risk of falls increases with advancing age. Impaired physical function, such as impaired mobility, difficulty with activity of daily living, and then a past history of falls are a good indicator of future risk of falls. Medical conditions such as some I've already mentioned: arthritis, stroke, Parkinson's disease, dementia, incontinence, and postural hypotension. And then sensory problems such as impaired visual acuity, perhaps they have senile cataracts, impaired proprioception in the lower limbs, perhaps because of neuropathy, and reduced depth perception. Other contributing intrinsic risk factors include musculoskeletal problems, reduced knee and hip ankle strength, pain in the joints such as the hip and the knee, foot problems, impaired plantar and ankle reflexes, neuropathy, as I mentioned, and reduced grip strength. Gait, balance, and physical performance also play a role. Gait abnormalities such as antalgic, hemiplegic, or ataxic gaits can increase your risk of falls. Reduced walking speed, as seen in increased frailty. Impaired dynamic balance impaired tandem walking and one leg balance, difficulty getting up from a chair. All of these are indicative of increased risk of falling. Cognitive impairment and depression. I mentioned cognitive impairment can result in a change in judgment and therefore a risk of more risky behavior. Medication use. We generally find that the elderly have a significant amount of ailments that they complain of as they get older when visiting a doctor. And generally, doctors feel compelled to prescribe medications to treat and manage these ailments. And before we know it, several doctors have added to the medication list, and you end up with polypharmacy, resulting in drug interactions which may increase the risk of falls. For example, cardiovascular medications such as antihypertensives and antiarrhythmics may result in hypotension or postural hypotension, and sedatives, hypnotics, anxiolytics, and psychotropics are commonly prescribed because of insomnia and maybe behavioral abnormalities, and these once again will increase the risk of falls. So with regards to the extrinsic risk factors, there's a lot of overlap here. Environmental factors such as just loose carpets, poor lighting, elderly people not switching on the light when they mobilize to the bathroom at night can be a risk. Slippery floors or an individual wearing wrong shoes, incorrect shoes that could result in tripping and falling. And again, activity related. So an elderly person who is running or hurrying or standing on chairs, climbing on ladders, this obviously puts them at risk as well. And behavioral and psychological factors, which basically entails the patient's perception of his or her capabilities. This is a bit of a busy diagram, but it just is a poster of what some of the intrinsic factors and things that can be done to avoid falls. For example, do not stand on chairs or boxes or to reach upper cupboards. Avoid alcohol and extension cords, loose cords, things that you could trip over, to avoid those, and wear properly fitting shoes and with non-skid soles such as rubbish soles, and avoid wearing high heels. And then basically making sure they have frequent checkups for their eyes, their heart, their blood pressure, basically their general health. Ensuring that they get some exercise because this will help with some of the strength and balance and coordination. And then in the bathroom, for example, one can install grab bars, which can assist them when mobilizing in the bathroom or when showering. And again, at bedtime, it's necessary to have a lamp near the bed so that if they are getting up to go to the bathroom, that they're able to switch this on. So there is a little bit of a difference between the scenarios that we see with patients falling in healthy individuals and in frail individuals. In healthy, active, elderly individuals, it's predominantly extrinsic risk factors. It's usually due to an overt environmental hazard, such as a very loose carpet, or risk-taking activities, such as climbing on the roof. It's often outside of the home, or more likely outside of the home. In frail individuals, it usually occurs during routine ambulation. It's usually without an overt environmental hazard, and it usually occurs within the home. So how do we assess physical function in the elderly? A handy tool to use is the pulse mnemonic. P is the physical condition. So you look at the physical condition of this patient. Do they have wasting of the intrinsic muscles? Do they have sarcopenia? Do they have a significant tremor? And is there any major problems that you can observe in their feet or hypertrophy, distortion of the toenails? U is for upper limb function. You can look at the proximal muscle function. That is usually when they are doing anything with their arms above their heads, such as brushing their hair or brushing their teeth. And then you want to know about their manual dexterity and fine motor function, which is very important for activity of daily living, such as tying their shoelaces, buttoning a shirt, for example. L is for lower limb function. This is the get up and go test, which I will mention very shortly. S is for sensory, hearing and visual activity. And E is the environment. Ideally, one should assess the patient's home. I know overseas they are able to do this. Here in South Africa, we don't always have the capacity to do that. So what is the time get up and go test? This is a very handy test that can be done in doctors' rooms. Anyone can do it. Basically, the patient is normally wearing their customary walking aid and using their normal shoes. And they get up from a chair. You ask them to get up from a chair with their arms folded, therefore not leaning on the armrest of the chair. Get up, walk 3 meters, turn around, walk back to the armchair and sit down. The timer ends when the patient has sat down. So up to 10 seconds is considered normal. Less than 20 seconds, or including 20 seconds, suggests that there is good mobility. The patient can go out alone and mobile without a gait aid. 21 to 30 seconds is really problematic, and usually these patients have to have a gait aid and cannot go outside alone. They need assistance. But what is important to know that anything from 14 seconds is considered a risk for falls. So as soon as you reach 14 seconds, this person may be at risk. So I just want to mention a case study of a Mrs. Thomas that I recently saw. She was an 88-year-old female. She had a background history of hypertension, which according to her is very poorly controlled, and she was referred due to uncontrolled blood pressures. Her general practitioner had her on palmisortan, 40 milligrams, which was then recently increased to 80 milligrams. She's also known to Dr. Lowe, and had recently had a pacemaker inserted and was taking a Pixaban, which is an anticoagulant, one of the newer anticoagulants. She has previously fallen on multiple occasions. However, her most serious fall actually resulted in a severe concussion. She complains mainly of insomnia and was previously on Stilnox, which has now been changed to Dorminoct, which is a benzodiazepine. She lives on her own in an apartment and walks with the use of a walking frame. So just listening to a history, some of the risk factors I have listed on the left. But one of the first things I noticed when she was entering my office is that she was using what was called furniture walking. She was accompanied by a daughter, but furniture walking is basically when the person walks holding on from one chair to the next chair, and then the table and so forth. Her physical examination, her blood pressure was measured sitting down and standing up, and she had evidence of postural hypotension. The blood pressure was at target, but I considered, that this might actually be too low for her due to the postural fall that she experiences when she gets up. Her hands grip strength was slightly reduced. She had evidence of sarcopenia, loss of muscle mass and strength. Her MOCA test was done, which is basically a mini mental, and did not pick up any cognitive impairment. She scored 26, although her daughter stated that she's confused in the mornings when she has spoken to her on the phone. The patient admitted that she's not always using her walking aid at night, and she then admitted that she sometimes just puts a chair in between her bed and where the bathroom is, and she then helps this chair to get to steady herself when she's getting up from the bed, which, as you can imagine, is not ideal. It's very easy to pull a chair over if you're trying to pull yourself up from the bed. And, the chair is stationary, so that's not the same as using her walking aid. And she also admitted to not even, switching on the light, mobilizing in the dark. And this is actually how the serious fall happened. She has no significant evidence of hearing or vision loss. Her get up and go test was 17 seconds. So just to mention the risk factors on the left, for falls that she has. She's previous history of falls. Her medication use. She's on benzodiazepines and antihypertensives. So she has sarcopenia and muscle weakness. She has a prolonged get up and go test. She has postural hypertension, and she has this history of possible confusion due to her sedatives in the mornings. So some of the interventions that I discussed with her with the initial consultation, I encourage the use of a walking aid, always turning on the light, not using a chair. I explained how this adds to the danger. I changed the benzodiazepine medication to melatonin, which is less likely to cause confusion in the elderly, and also the kind of hangover effect that she was experiencing in the morning. I reduced her antihypertensives to actually allow the systolic blood pressure to go up to about 160, as has been suggested by some European anti-hypertension guidelines, just to allow for this postural fall that she has due to the stiffening of her blood vessels or arteries that we see in the elderly, because we don't want a significant drop or a blood pressure to be perfectly controlled and then actually hypotensive in the upright position. I also suggested that they consider further assistance due to her functional decline. I also requested that she goes for a DEXA scan, bone mineral density test, to assess and treat osteoporosis or osteopenia should she have it. And I referred her to a physiotherapist and a biokineticist to assist with some exercises to allow for strength training and rehabilitation, of muscle strength to reduce the risk of falling. So usually, as I said, because there's such a multitude of risk factors, it involves a multitude of interventions. Usually a comprehensive geriatric assessment is needed to assess, across all domains, including physical, mental, social, economic, functional, environmental factors. You may require, referral to an occupational therapist. You may require a social worker, especially if the patient is needing to go into a care facility to assess the social support of the patient. In the elderly, we always consider non-pharmacological interventions before you add to the drug list that they're already on. And when you do need to use a drug, you need to consider a drug with the least side effects and something that is affordable for the patient, and maybe use the drug at the lowest effective dose and avoid sedatives and psychotropic drugs. Again, you need to avoid polypharmacy. You need to perhaps go through some of your job when assessing a patient who is a geriatric patient, would be just to go through the medication list and eliminating those medications that may not be beneficial to them anymore, and may not be affecting their quality of life, and basically eliminating that. You may need to refer to an audiologist, an optometrist, an ENT, or an ophthalmologist if you think there's significant hearing loss or visual impairment, to try and improve this. Again, you may want to improve environmental safety, assess, where they are staying. Is there a lot of staircases that they need to climb? Is there good enough lighting? Do you need to suggest that any handrails be put into place? And then family and patient education around falls and avoiding risk-taking behavior is important. And often when you assess these patients, you need to have a family member with them, because if they're elderly, they're not going to be able to implement any environmental things on their own. They will need a family member to assist them with this. And, that's why it's important. So Mrs. Thomas's bone density, looking at her T-score, you can see, I've interpreted there for you, but basically she has osteoporosis involving her hips and her forearms. And, should she fall, she's high risk for actual fracture of these limbs. So her FRAC score, which I've mentioned and explained in a previous talk I did on osteoporosis, indicated that her 10-year risk of major osteoporotic fracture is 23% and 14% of a hip fracture. So that's very high, I did do a basic osteoporosis workup in this patient, doing calcium, magnesium phosphate, serum protein electrophoresis, checked her vitamin D levels, thyroid stimulating hormone, T4 and parathyroid hormone. And I decided that she's a very good candidate for bisphosphonate therapy. Vitamin D deficiency and insufficiency is common among elderly patients, and also further results in impaired muscle strength. So it's important that we identify this and supplement. Combined calcium and vitamin D3 supplements have been shown to actually reduce your fracture risk. So would be beneficial in these patients. So just to demonstrate some of the interventions that you can find on the internet that are not really recommended. This is things like hip protectors and breath, things like they're basically sponges and strange underwear that the patients can put on, and full body suits. But none of these, you can buy these airbag suits on Amazon.com. But basically, this none of these have been shown to be beneficial. So even though it seems that in theory you could be making a difference, it's really just a waste of money. So what are some of the take-home messages? You always need to inquire if a patient aged 65 years and older has had any falls within the last year. It's important to assess their functional class, their physical function. You want to evaluate their fall risk going through intrinsic and extrinsic factors. And you always need to remember the time get up and go test. And just in brackets there, 14 seconds is already a risk for falls. You want to check their medication list, and you need a multidisciplinary intervention to mitigate the risk. And you always need to screen for osteoporosis. Thank you so much. That brings us to the end of my presentation. I wish you all a good afternoon.